Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for your company this evening. Our programme tonight focuses on anything and everything to do with the blood. In particular, we'll be discussing iron deficiency, thrombophilia screening and estrogen therapy, lymphocytosis, early detection of leukemias and shared cancer care. We'll also talk with haematologist Dr. Steve Ward about iron deficiency, including the use of intravenous iron infusion. And then later, Steve Ward will also talk with us about the management and treatment of multiple myeloma. But before we leap into the program, can I give you a final reminder that this year's annual conference and trade exhibition returns to the Intercontinental Burswood on the 26th and 27th of April. If you still haven't received a registration brochure for the conference, then please call Rural Health West as soon as possible on 08 6389 4500. Now let me introduce our panel for this evening's program. To chair the discussion tonight, we are delighted to welcome back Dr. Felicity Jeffries after such a long time away. Welcome back, Felicity.
Thanks, Jerry.
Dr. David Joske is Head of Haematology at Sir Charles Gardner Hospital and Director of Solaris Care Foundation, its Cancer Support Centre. Welcome, David. And Dr. Catherine Cole is a clinical haematologist at Princess Margaret Hospital and Path West and is Professor of Pediatric Haematology and Oncology at UWA. Welcome, Kathy.
Thank you.
Now, before we begin, a reminder that this is an interactive program, so if you have any questions for Felicity, David or Catherine, you can have your say at any time by giving us a call on 1-800-673-277 or 089-229-5241. Well, Felicity, blood is the topic of discussion. It's over to you.
Thanks, Jerry. Welcome, Kathy, and welcome, David.
Thank you.
Hi.
Okay. I thought even though we were going to talk about iron deficiency later on in the program, because it's such a common presentation in general practice, we might start there tonight. Kathy, with young children who present with iron deficiency anemia, what should the rural GP do? Should they be referring to you, or should they be investigating a bit further themselves?
The most common iron deficiency we see in children is in the very little E's, aged about 1 to 3. You usually have enough iron stores to get through the first year of life. But after that, unless you've got a decent diet, you'll become iron deficient. And so most of the children just have a poor intake of solids and are drinking too much milk. Mm-hmm. And most of them really can be cured by changing their diet without having even any iron or just some oral iron, which is well absorbed with fruit juice. And very few of those children would need any further investigations. In fact, it would be perfectly reasonable to give that a decent trial. I say throw the bottles away. That's the most important thing.
I suppose, I see a lot of Aboriginal patients in the northwest who've got chronic infections and things as well. Will diet just fix that with a few?
Some of them may need anti-parasitic antibiotics as well.
Yep.
Particularly if they've got an eosinophilia, so if they've had a blood count, which is they usually will have to diagnose the iron deficiency, then the eosinophilia is really the indication that it's a good idea to give them a dose of flagyl or something as well.
Okay, so oral treatment, and if that doesn't get them better, then?
Yeah, and from my point of view, if kids have had a good go at that, I'll often actually defer the referrals either to general paediatrics or straight to gastroenterology, because although we diagnose iron deficiency in the haematology lab, it's not a problem of the blood system per se. It's really just a matter of iron either not being absorbed or being lost, which is usually through the gut. So if kids need investigation, it's really from the gastroenterologists.
Right, yeah. David, what about in the adult population? There's a lot of iron deficient anemia around and a lot of symptomatic people that, it's really hard for the GP to treat. What would you advise them to do?
Well, I guess the first thing I'd say is that I disagree with the textbooks, which have this stated view that people only get symptoms if they're anemic. And I really have seen so many people now where we've replaced iron levels with a normal hemoglobin and people feel a lot better. And the kind of symptoms that they notice improving, for example, after an iron infusion, are a kind of clearing of the head. People feel then able to concentrate better and they're no longer thinking through a cloud of cotton wool. Better energy levels. And there's also a mild kind of, almost like a peripheral neuropathic kind of symptom that I think adults experience when their iron levels are low. So I've had a lot of very grateful patients when you can see by their ferritin that the iron levels are very low, but the haemoglobin and even the menstrual volume are normal, but they're very symptomatic.
So when their ferritin's low, do you investigate why that is, or do you just put them on a iron supplement?
It's on a case-by-case basis, and I would say that it's invariably women that I see, mostly in the 10 years after having children. Each time a woman gives birth, she'll lose about 20 to 40% of her iron stores. And of course, the fetus in utero gets preferential take on the iron that is absorbed, so it's often a pretty parlous iron balance at the end of 2 or 3 children. Whether you investigate, I think, depends on your index of suspicion for something nasty. And if there are no symptoms that suggest blood loss and a normal physical examination, then, and particularly if there's a diet that sounds pretty poor in iron, I certainly wouldn't do pan endoscopy on everyone.
Yep. So once you've treated somebody with like an oral iron supplement and it's not actually working, what would your next line of treatment be?
When I'm treating somebody for iron deficiency, number one, I'd never do a transfusion unless they were a very elderly person with life-threatening angina. They will always respond to the iron if you can get it in.
And can I interrupt a minute? Kathy, would you say the same with children?
Yes, absolutely. Yeah. Even the kids who come in with a very low haemoglobin, sometimes even under 30, will respond to iron. I keep them in hospital for a few days just to make sure they're reticking and they've had some good dietary advice and thrown the bottles away. But I don't transfuse.
Because it can be very tempting to when they're very low.
I think in an adult hospital they often get the transfusion so they can get the endoscopy done on the same admission. Whether that's cost effective, I'm not sure. So when I'm starting somebody on iron therapy, I'll always go through with the patient basically warning them that when they're iron deficient, usually the bowel flora is as well. And so when they start taking iron, the bowel flora goes crazy, and that means a lot of unpleasant wind, top and bottom. And so I suspect it's one of these social unmentionables that a lot of people don't follow through with their iron therapy because they're getting unpleasant wind. So if you warn people that that's going to happen, that helps prepare them for it. Make sure they don't take it with a cup of tea because the phytates in the tea chelate the iron effectively, make it unavailable for absorption. There's preparations now, Ferrograd C, which has the vitamin C built in. And so I would say to people, try and take 1 Ferrograd C tablet once a day. Fefol, for example, has 1/4 the amount of iron. It's really not an adequate iron replacement treatment. Have it with a cup of orange juice. If you're getting a lot of wind, have a lot of live culture yogurts, which will get normal flora into the bowel and tend to reduce that. But in my experience, there's still about 10% of people who are genuinely intolerant of oral iron, who will even get bowel pseudo-obstruction and severe cramps, or the opposite, diarrhoea. And my own practice has warmed, I think, towards using iron infusions. I'd never use intramuscular iron. It sits under the skin, it's poorly bioavailable, it leaves rust marks and doesn't really benefit the patient at all. And I've changed in the last 10 to 5 years now to using iron infusions much earlier.
And how do you do that? What do you actually practically do to do an iron infusion?
Well, part of the reason I've changed is because the Ferrum H preparation changed about 6 or 7 years ago now to one that doesn't have the cardiac side effects. With the older preparation, we had to start people very slowly, drop wires and monitor them for cardiac arrhythmias. That really doesn't happen anymore, and we don't actually monitor now. We start slowly because of the risk, as with anything IV, of anaphylaxis. And I've been more prepared to give bigger doses. So I'll put, for example, 1600 to 2000 milligrams of ferrum H into 500 mils of normal saline. Start it slowly and expect to give that in 3 or 4 hours. I'll warn patients that most people will get 48 hours of arthralgias.
Yep.
Best treated with Panadol. Occasionally people get more severe pain. And in my experience, most adult patients start to feel the benefit of it somewhere between 2 days and 2 weeks.
And how long between treatments?
Assuming the ferritin's below 30 in men and premenopausal women, that kind of dose of iron I'd expect to get the ferritin up to around about 250.
Yep.
With oral iron I'd aim to get the ferritin to 60 or 80, so about twice the lower limit of normal. And then repeat the iron studies and the ferritin level something like 6 to 8 weeks later as a guide to whether we're into a steady state that's staying or is starting to drop away again.
We might leave that there and go on to something else and see how it's covered in the insert. Okay. Kathy, ITP is a very common presentation for young children, especially after a viral infection. And again, as a rural doctor, it can be quite frightening seeing a child with very low platelets.
Yes.
When would you treat a child with low platelets? What would be the indication to actually say, I should actually do something about this?
There's 2 issues with ITP.
Yeah.
One is being happy that it's the diagnosis, because no one wants to miss an acute leukemia.
Yeah.
And really, as long as the rest of the blood count is normal and the platelets are very low, usually under 20 and very often under 10 in children, that's a classical picture, and we're really happy to say it's ITP, and we really don't do nearly as many bone marrows as we did, say, 20 years ago. If there is something unusual about the blood picture, then we would do a bone marrow if we wanted to treat with steroids, because that's really the risk, that we don't want to mask a leukemia or put someone into tumour lysis and damage their kidneys. So having decided that it definitely is ITP, then the question is whether to treat or not, and generally I don't, and that's a pretty common practice now, unless kids are bleeding. So if they've just got bruises or just got epistaxis, as long as it settles and they're fine, then I don't routinely treat them. And about 70% will get better within about 4 weeks, and about 90% within 3 to 6 months. Now, it depends a little bit on the child and the family and where they are.
Yeah.
Some very small children, you just, feel like it's going to be a nightmare trying to keep them from falling or doing whatever they might do. I certainly say that they shouldn't ride bikes or jump on trampolines, but they should go to school if they should be able to go to school. And mostly people are happy with that, not having their children treated. I try not to look at the blood count too often. Kids hate having blood tests.
Yep.
But again, parents are anxious to see the counts getting better. And then it becomes, again, a feeling with each patient as to how long we'll let it go. So if at the end of a month there's really no change, some parents are happy, they're used to it by that stage and they just want to wait and see, and others are really frustrated, or the child wants to play soccer or whatever. And it used to be that they had to fail steroids in order to get Intragam, but the new Intragam guidelines, which came out just 2 weeks ago, now allow us to give Intragam first, and it probably has better effect at bringing the platelet count up. Requires an intravenous infusion, so you can weigh that up as well.
Yep.
But the side effects of 2 milligrams per kilo of prednisone for a couple of weeks are significant as well. So one treatment suits some kids more than others. The effect of both of the treatments are usually successful, although not always. Some kids fail steroids and end up waiting again or having some Intragam. Most people will respond to Intragam, and it lasts about 3 weeks, after which time they may get another dose, or they might be then starting to recover anyway. So we don't get very many children with chronic ITP, and in fact it's really only at that stage that they end up getting referred to us.
Yeah. What about adults, David, with the chronic ITP?
My first comment is half your luck, because in adults ITP has a much worse prognosis. In adults we've changed the investigation algorithm also away from bone marrow biopsies. There's something which I rather pompously call Josky's law. And we're going to talk about early diagnosis of leukemia in the second half, but Josky's law states that the risk of leukemia or a serious bone marrow disorder is directly proportional to the number of the 3 cell lines on the blood count that are abnormal. So if all of them are out of whack, then really a bone marrow biopsy is needed. In ITP, in somebody who's under 60 and with no symptoms that would suggest an underlying malignancy or chronic viral infection or autoimmune disorder, we wouldn't do a bone marrow biopsy. We always screen for lupus and HIV and the hepatitis viruses. But most of the time now in younger, well people with an isolated thrombocytopenia, if those tests are all negative, we assume it's ITP and start pretty similar treatment, really.
We might just go back to the bone marrow that you both referred to doing. We did have a question from a GP about the techniques of doing a bone marrow biopsy. What would your advice be to somebody in the country?
Well, with regard to the specifics of the technique...
well, the advice of doing one.
When we are investigating possible leukemias, there's about 6 different tests now that we do on a bone marrow aspirate and trophine, some of which involve isolating RNA and DNA, which have to be processed very quickly. So in fact, even if a biopsy were done in the country, we'd have to repeat it in the case of leukemia or lymphoma. So probably most of the time it's best left till the patient gets up and spare them the discomfort.
Knowing that it's going to have to be done twice. And that would be
we use an anaesthetic in children, and I'd be a child if I ever had to have one.
So best to wait till you've got the diagnosis and refer into Perth for more treatment.
And particularly in leukemia, they actually sign 2 or 3 consent forms for various studies before we even do the first bone marrow. So it's a complicated process of getting them on clinical trials and so on, and collecting specimens as part of the trials.
Okay. We were going to talk a little bit about thrombophilia too. When would you actually diagnose somebody with thrombophilia? What would be your reason to say this person needs to be investigated further?
Well, actually, strange enough, most of the patients that I see are already diagnosed. And the question's arisen what to do about it.
Right.
And I'd have to also say I'd far rather have a horrendous case of CNS lymphoma than some of the women who are referred to me with a diagnosed thrombophilic state and advice about either estrogen as an oral contraceptive pill or as hormone replacement therapy. It's a really difficult area. So there are some numbers that we can use to back up some kind of evidential basis. It's pretty important to make a distinction between a thrombophilic state, something we can measure in the blood that we know predisposes someone to clots, versus the risk factors for thrombosis that include trauma and surgery and immobilisation and economy class syndrome, so-called. And nowadays there's about 8 different entities that we test for, at least at PathWest, some of which are DNA tests and some of which are clotting-based tests, which may pick up an increased risk for getting a clot. And the problem then is, if you've got somebody with one of these factors present, what advice do you give them about taking estrogen in any form, which purely and simply in a dose-dependent way increases the risk of clots? We know that people, for example, with factor V Leiden, which is present in about 3% of Caucasians, aren't at increased risk of a second clot. So they should just be anticoagulated for the first clot for 6 months and then managed in the usual way. They should be preemptively managed for high-risk situations. As far as giving estrogen goes, there's a little bit of evidence, for example, that transdermal estrogen is less thrombogenic than oral. 2 out of 3 studies have suggested that. But it's always going to be a risk, and in the end, a woman has to make that decision.
Okay, we might leave it there for a minute. Back to you, Jerry.
Thanks, Felicity. Well, as we've been discussing, iron deficiency is a common problem, and while there is a range of treatment options, there's been ongoing discussion about the efficacy of intravenous iron infusion as one of those options. We asked clinical haematologist Dr. Steve Ward to talk us through iron deficiency and give us his advice about the use of iron infusion.
Iron deficiency is very common, and it's a real major concern for lots of people, particularly women rather than men, because they've got less iron stores than men do, so they run out of them more quickly. The main causes really are dietary, but that doesn't occur in Australia very often at all. Most people eat reasonable diets and get plenty of iron in. Malabsorption can be a problem, so people don't absorb iron. Again, that's less common, but things like celiac disease are reasonably common. And if you've had surgery to your gut, then you can obviously, particularly small bowel, you can lose the ability to absorb iron. The most common cause of iron deficiency is probably menorrhagia in women, and that's a major problem. And the other major one is blood loss from other reasons, such as ulcers, angiodysplasia of the bowel, or bowel tumours. Because iron deficiency is a very common problem, we often get the sort of dilemma of how much should we look into it and see what's causing it. We know that menorrhagia in women is a very common cause, and if you get presented with a lady with menorrhagia, is that going to be the end of it, or should you look for ulcers and bowel sort of cancer as well? And I think in a young, fit person who's got no bowel symptoms and is otherwise well and has significant menorrhagia, then I think you can probably stop there. In somebody who's getting towards middle age and older, particularly in men with iron deficiency, you should certainly look at the bowel every time. The treatment of iron deficiency is really, first of all, to make sure that you've got a diagnosis right first. So the diagnosis of iron deficiency itself is sort of only half there. You need to make sure that you've got a cause for it, whether that's menorrhagia or bleeding. Then you've got to treat the iron deficiency as well. And there are a number of ways to actually do that. Oral iron is probably the best. Iron tablets, although they are not very well tolerated by quite a number of people, so they have downfalls as well. And a lot of people just don't take them, or start taking them and stop, or go on to the sort of more homeopathic doses, which are great because they feel okay, but they don't get enough iron in. Most of these over-the-counter iron preparations have got something like 1 or 2 or 5 milligrams of iron, and they only absorb 1%, maybe 2%, 5% at the most. And most people need between 1 and 5 milligrams of iron to be absorbed every day. So mostly you need to use the full-strength iron preparations such as Ferrograd or Ferrograd C, which have got 100 milligrams of iron in it, and you can therefore absorb 5 to 10 milligrams. The problem with that is it causes gut upset, and people get either constipation, diarrhea, bloating. A lot of the time that will settle down when the iron deficiency is treated, because the gut bugs that live in your gut are also iron deficient and quiet. You feed them iron and they get very active and start making gas, and you get bloated, and that causes a problem. Often that will settle down over a week or two, particularly if you start taking the iron tablets with food rather than on an empty stomach, and explain to the patient that should settle down. But having said that, there are a lot of people who just can't take iron tablets and get really bad symptoms. Other oral preparations, apart from ferrous sulfate, like ferrous gluconate or liquid preparations, really don't have many advantages over standard iron therapy, and really it's worth trying, but it's really not going to make any difference. Intramuscular iron is available. I think that's cruel and nasty, and you get a 2 ml injection each time, and you've got to use a sort of Z technique to make sure that you don't get rust marks forming, and you need to have frequent injections, and I don't think they're any better than the oral iron. The only other alternative really is intravenous iron, which used to be thought of as a no-no, completely bad with lots of side effects, potential for anaphylaxis and occasional deaths. That did occur in the old days, back in when the iron wasn't very pure and was mainly a dextran preparation, and a lot of the side effects are related to the dextran with allergy to that. These days we use low molecular weight dextrans, and it's iron polymaltose, or Ferrum-H, or Fersig is the trade name for those, and they are much safer, and the risk of getting problems is much less than 0.5%. So we now give iron infusions. I do them probably about 8 or 10 a week now, and we very rarely get any problems. If we start with a small dose, a little bit, crank it up gradually, keep an eye on the patient. I always do them in a hospital day ward so we can look after the patient properly in case there is any anaphylactic reactions, which thankfully are very uncommon. The only side effect of intravenous iron is it takes time. It takes 4 or 5 hours to actually give a complete dose, but you get all the iron in one day that will get your hemoglobin back to normal within a week or 2 or 3, and will also give you plenty of extra iron to store away to keep and use over the preceding months to year, hopefully. Intravenous iron can also cause a flu-like illness a few days after it, which is quite common and isn't a major concern, and I just warn patients it might happen, and if it does, it's just a nuisance. One important point really is that with iron deficiency is that the only thing you can really say with 100% confidence is that a low serum ferritin level confirms iron deficiency. If it's normal or borderline or high, you can still be iron deficient, and the ferritin's pushed up by inflammatory markers and inflammation, and it can be really difficult to sort out. The other important thing to say is that you must look for a cause of iron deficiency in the majority of patients, and the sort of treatment can be difficult. Hopefully you'll get away with iron therapy orally. If not, I think using intravenous iron is becoming a lot safer and a lot easier, and can certainly be done in local hospitals without any major side effects.
Dr. Steve Ward there with his thoughts about the treatment of iron deficiency, and we'll be hearing more from Dr. Ward again later in the program. But before we return to our studio discussion, pardon me, a reminder to call in at any time if you have any questions or comments for our panel. The number is 1-800-673-277 or 089295241. The continuing discussion on blood, Felicity.
I thought we might talk now a little bit about acute leukemias, and I suppose all GPs are worried about missing something like this. What are the type of symptoms, we'll start with you David, that would alert you to thinking about somebody might have an acute leukemic symptom?
Well, I actually think the best way to start on this is a history lesson. When we first started looking at blood down the microscope, in fact Virchow in 1876 coined the word leukemia, referring to people who had too many white cells in the bloodstream, and the word actually means white blood. And pretty soon after that it was realised that some people had way too many white cells and they looked pretty normal, and those people seemed to live a long time, and so that was called chronic leukemia. Other people had way too many white cells, but they were very abnormal looking, very primitive, in the modern parlance blast cells, and they died very quickly, and so that was called acute leukemia. Nowadays, acute leukemia actually refers to cancer of the bone marrow stem cell, and specifically to more than 20% blasts in a bone marrow biopsy. So the use of the word leukemia has actually changed, and the corollary to that is that in acute leukemia, specifically, rather than chronic leukemia, the white cell count can be low or normal or high. It can be anything. Right. And so, whereas before we used the word to mean too many white cells in the blood, nowadays we're talking about a cancer. And it's as if the blasts are sticky and stay in the bone marrow, or not sticky and get in the bloodstream. It's as simple as that. So then we go to Josky's law. If all 3 of the blood counts are abnormal, then really it looks like the patient should have a bone marrow biopsy.
And they need to really come to a major centre to do that. Yep.
Then the next point I would make is that patients with cancers of the bone marrow end up with what I call the positive and negative symptoms of haematology. So the positive symptoms are the textbook B symptoms. unexplained weight loss, so you know the Jane Fonda videos don't count. Night sweats, characteristically drenching, and usually that's striking that the patient pretty much remembers when they started. And then unexplained temperature greater than 38.5 on 2 occasions. And a bunch of other symptoms common to all malignancies like pruritus and spontaneous intolerance of cigarette and meats and alcohol, which I think are very common in cancer patients. So those are what I call the positive symptoms of an abnormal population pouring out cytokines that affect the way people feel. But people with leukemias have cancer of the bone marrow, which means the bone marrow stops working so well, so they get the negative symptoms attributable to the lack of white cells, infection, lack of red cells, anemia and shortness of breath on exertion, and lack of platelets, bleeding. So if somebody, for example, has a sore throat, very reasonable to prescribe antibiotics, but for heaven's sake, if they start getting more sore throats and it's just happening repeatedly, then a blood count needs to be done.
How important is it to pick it up early? Does it make a big difference to the treatment if you delay diagnosis?
Look, I should say yes, but in practical terms, the prognosis isn't affected a lot. You know, of course, we see patients where it's diagnosed late, and I'm thinking of a chap I saw a couple of months ago from one of the country towns. But his outlook wasn't greatly changed by any delay in diagnosis, and some of them are very rapid in onset. And others, on the other hand, we talk about smouldering leukemia, which is really where there's a very slowly growing acute leukemia, which can be present for many years before it's picked up.
Okay.
So it's a different situation perhaps to breast and lung cancer, where early diagnosis means surgery might be possible.
Yep.
The blood cancers, leukemia and lymphoma, are not treatable with surgery.
No.
Beyond a biopsy.
Okay. Kathy, I might go to children. Is it a similar situation with children, or?
The presentation is a little bit different. We see 3 main settings. One is the child who's had what appears to be a viral infection that just doesn't get better. The bruising child who ends up with a blood count. And then the common one actually is the child with a limp and bone pain. And it's literally from the marrow being stuffed full of leukemia, and it hurts. And it's surprising how long it takes before that child gets a blood count.
Yeah.
Even though leukemia is more common than juvenile arthritis, people don't like to think of it first. Actually, leukemia probably is a better disease to have in many ways than juvenile arthritis, but people still don't like it.
Yeah.
It's a rare disease. We'll only see 25 children under 15 each year with leukemia in the whole state.
Yeah.
So,
and how many of them are likely to be from the rural area?
well, the percentage of the population, so 25% of the population. So there are not too many out there, and they do, as David said, it's not going to go away. I mean, it'll be diagnosed, and the biology of the disease is the same whether it's diagnosed this week or next month. And
so what about if you're out in the country again and you've got somebody with symptoms, a child that's limping or something, what's the first blood test that you should do apart from just a full blood film?
Looking for leukemia?
Yeah.
Well, really that's the most important, and then using Joski's rule to decide where to go to next.
Yeah.
People commonly do an LDH, or lactate dehydrogenase, and they're reassured if it's normal and worried if it's abnormal. I'm not so sure that it's a particularly useful test.
Yeah, I'd just make a little distinction between a full blood count, the numbers, and a film, actually looking at the cells, which is important if somebody's suspicious.
Right.
Yeah.
Right. Are there any other tests that you do, or once you've got the abnormal, you've got 3 abnormal variables, you would actually go further and go onto the bone marrow? Or?
Yeah, pretty much, yeah.
Yeah, okay. Once we refer somebody to Perth, so we've got somebody that we think's got an acute leukemic syndrome, you know, what should the rural doctor be saying? You're going to be going down for a long period of time. So start with the adults. How would you talk about the long-term treatment? Or
Okay, well that's, I guess the first thing is that I don't use the L word until I've made the diagnosis. And I will actually be very euphemistic, and it's the same with the blood films that I report. The strongest wording I would put on a blood film report is to say that this could represent a leukemic process. And I've said that probably twice in the last 10 years when it was, but even then I don't like using the word until somebody has a chance to speak to the patient with knowledge of what leukemia entails, because it's a scary word in our society. And that incidentally is a burden for the people with chronic leukemias, which are quite a different situation. So with a newly diagnosed patient, the things that I would go through are to try and give them a practical slant on the amount of time the treatment's going to take. Basically it's 3 to 6 months of intensive chemotherapy one way or another. It has gotten shorter and it has gotten easier for people. And across the board, one positive we can dwell on, even in the gloomy world, for example, of adult lymphoblastic leukemia, which has probably got a long-term survival still around 25 to 40%, is that at least 80% of patients with acute leukemia will go into a remission first up. So there's a positive you can concentrate on. I'd stress to patients that it's not infectious. You can't give it to your partner. It doesn't run in families. 99 times out of 100 we can't tell someone why they've got it. And as much as possible we'll try and delay treatment for 3 or 4 days at least, to give them a bit of a chance to get their head around the situation that they're in, if possible, a weekend to get back home and sort a few things out. It may be appropriate to try and get semen cryopreserved in men, or even try and collect eggs in women, but that's a very difficult area, not usually done in acute leukemia. There's just not time. And if possible, to try and give patients a chance to consciously choose to opt for their treatment. I think this is really important in cancer generally, to go through the options, and when there's a cancer diagnosis, the options are try and cure it, try and control it, or do nothing. And I will always make those options explicit to people and say my best take on what will be the consequences of each choice. And this is more appropriate perhaps for a very elderly patient with AML, where palliation might be a better thing to do than trying to battle through 3 cycles of very intensive remission induction chemotherapy. But doing that gives patients a chance to feel like they've got a bit of the control back, and then there's a feeling after that through their care that you're kind of rowing in the same direction with them. Not that they've been snowballed and, hey, you've got this and do what we tell you. And
Might come back in a minute. I think it's a little bit different with children.
It is a bit different. We've been very lucky in children. We've had everyone in the first world has worked together in large international groups enrolling children on randomised trials of treatment for children with acute leukemia for over half a century now, such that the treatment's actually got more intense rather than less in children, and the cure rates overall are 80% and in fact over 90% in our standard risk children under age 10. So that we delay treatment for a few days to hydrate them very well so they don't get tumour lysis syndrome, rather than for the other reasons that you've said. And it is a sort of bombarding situation where they have to learn an enormous amount, and in fact they do, in the first 3 or 4 days they're in hospital, the families sign 4 different consent forms for various parts of investigations and treatments and studies and so on. As a result, we're aware of quite what a dramatic change this is on the whole family's life, and we have an entire team approach to it, and that is easier, much easier to do with children. But as a result of that, they've done extremely well. They're in Perth for most of the first 2 months of treatment and then variably thereafter. And the treatments in fact go on for a very long time. They go on for 2 years in girls and 3 years in boys, but after the first 6 or 8 months, that's actually what we call maintenance therapy, and it's all given at home with only 3 monthly visits to Perth. So in fact there is a lot of work that all our country doctors do for looking after those patients.
I suppose what happens then is that you've got a group of children that have had long-term heavy therapy that are going to have follow-up. for the rest of their lives. And I suppose the understanding of the side effects of the different treatment regimes become important.
Certainly in the past, when initially virtually everybody had cranial radiation as part of CNS prophylaxis, we were very concerned about long-term effects of therapy. With modern therapy for standard risk childhood leukemia, we really feel that our aim is for there to be no long-term side effects. They don't get enough alkylating agents to cause infertility. They don't get enough of the group of drugs that can affect the heart function for that to be a concern. They no longer get radiation. So we are pretty happy that our patients in long-term follow-up can be followed up by postal follow-up and without specialist care necessarily. That contrasts enormously, as you can imagine, with our solid tumour patient population, but we won't talk about those tonight.
Not tonight, another time. Is there the telemedicine, has that become useful at all in the treatment with some of these patients, with just being able to, I suppose, more for the support rather than the medication?
We speak a lot on the phone. We haven't yet got into video, or the need for videos really. We foresee the day when we'll be looking at films electronically, and that is coming. The software now is really very good. But there's not so much of a need in haematology for seeing the patient on video.
What about shared care in the adult population, David?
Well, I just want to make one other comment about cancer in general, because it's something that I do feel passionately about. You know, we're talking about follow-up and so on, and there's an impression which I think the media reinforce, that cancer is this devastating thing where people have a lump and they get treatment that makes them look and feel terrible, and 3 months later they're alive or dead. So for example, in the case of Delta Goodrum or Kylie Minogue, in Kylie's case, diagnosed now about 18 months ago, I sense that the media are really dying to say, look, she's cured. But the point I'm trying to make is that even if she were cured, she won't know for another 3 to 5 years. And the modern view is that cancer is a chronic illness, and that people need supports as for chronic illness. And this is even if they're cured. There's a whole growth area, no pun intended, on survivorship and the issues of taking up life and relationships after cancer diagnosis and treatment. So even if somebody's cured, they've got to live with this shadow over them and the fear of relapse for quite a long period of time. Now, shared care can be defined, at least from the GP's point of view, as allocating specific roles to the GP in cancer management. And I'm a believer, and I don't think it would be a surprise to our audience tonight to know that a lot of my specialist colleagues are not. And I've got to be perhaps a bit controversial and say that I think some of that is sadly financially driven. But probably a much bigger reason is that as specialists we do the physician's exam, and mistakenly I think a lot of physicians believe that that makes them, we learn so much about so many things to pass that cursed exam, that people feel like they know about everything at least once in their lives and can look stuff up if they need to look it up again. So physicians feel like they are holistic in a sense. We're kind of disease holistic rather than health holistic. So a lot of physicians feel like with the training they've got that they should be able to manage the patient entirely themselves. Now I don't, and I think I need around me a team to provide all of the other things that I can't give to my patients. I think it's very important that my communication with them is, and that they learn that their communication with me is sufficiently honest that we can cut straight to the meaty stuff, because I have pressure on my time. And so my 10 or 15 minutes with each patient, they know that they can ask me the death and dying stuff and the prognosis stuff because of what's happened before.
And I think that's important. On that note, I think we may have to wind up, so thank you. Back to you, Jerry.
Thank you, Felicity. I think there's probably room for an Andrew Denton interview and enough rope with David on some of those thoughts on cancer care. Our final segment tonight is a discussion on a condition that until very recently had a very poor prognosis indeed, multiple myeloma. Dr. Steve Ward was kind enough to talk us through the condition and give an update on treatment options. And as it turns out, there have been some significant advances in the management of the condition in recent years.
Multiple myeloma is a hematological malignancy. It's a cancer of the bone marrow, bone and blood, and it really causes lots of morbidity, and it still kills people. It's got quite a significant mortality. Thankfully, it's becoming less of a bad stigma these days. It is treatable, and treatment works well, even though in the vast majority of patients it's not curable. It's certainly controllable, and most people live reasonably normal lives with treatment for a significant length of time. Myeloma is a condition of a cancer of the plasma cells in the bone marrow that produce too much immunoglobulin, too much antibody, and that causes lots of the problems. It causes hyperviscosity, drowsiness, it causes bone marrow failure, so you get anemia, thrombocytopenia, neutropenia. It can cause hypercalcemia by nibbling away at the bones. Again, that causes major problems. It also causes problems with plasmacytomas, so lumps of plasma cell tumours in bone, and bone fractures are a common and significant problem with this. Myeloma can present to lots of different people in lots of different ways. These days, a significant proportion are picked up asymptomatically. They happen to have a blood test done and they get a high total protein level, and that should ring bells to say high total protein. What's the protein? We look for a serum paraprotein, and that's not an insignificant number of people. Most people present with symptoms, however, still, and the symptoms are things like back pain is very common, being upright people standing rather than on all fours. We put a lot of strain on our back and our spine, and a lot of problems in myeloma relate to spinal fractures, and that causes back pain. Particularly crush fractures. Osteopenia or osteoporosis can also be a major problem without actual holes in the bones or lytic lesions, which are the other things. Some people present with pathological fractures. Some people will present just with tiredness or anemia, and certainly in the elderly population, anemia that's not otherwise easily explained, you should think about doing the serum protein electrophoresis to look for myeloma. To investigate the potential for myeloma, the tests really are to look for serum and urine paraproteins. Most people will have a serum paraprotein. Some will not have a serum paraprotein and only have a urinary paraprotein, about 10% of myeloma. Some myeloma is called non-secretory, which is not common, but they don't make any paraprotein, and you look at other things such as the bone marrow, which will be diagnostic often, and a skeletal survey doing x-rays of the major bones looking for lytic lesions is the other way to look for it. There is a new test which is more sensitive, and its place isn't quite cemented yet, but looking for serum-free light chains in the blood is helpful. Rather than looking for the whole immunoglobulin molecule, you're looking for serum-free light chains, and you're looking for kappa or lambda being much bigger than the other, and that will be a pointer towards myeloma or lymphoma. It's hard to diagnose sometimes because there are certain criteria that are meant to be met to make the diagnosis, and there is a gradation of people who have simply a serum paraprotein, and that's called, unfortunately, long name, monoclonal gammopathy of uncertain significance, or MGUS. And those are people generally more elderly. It tends to start in the 60s, gets more common through to the 70s and 80s, and about 1 to 5% of 80-year-olds will have a serum paraprotein with no evidence of anything else there. Unfortunately, that's not the simple end of the case. About 20% of those people with what seems to be an innocent serum paraprotein will go on to develop a plasma cell disorder over 10 to 20 years. So whether that's lymphoma, myeloma, or Waldenstrom's macroglobulinemia has to be looked at. So if somebody has a fairly small serum paraprotein without anemia or hypercalcemia or bone lesions, none of the things that could make the diagnosis of myeloma, and low plasma cell numbers in the marrow, then they should be monitored annually and to check to see if they do go on to develop something or not. Myeloma itself, when it starts, can be indolent or smouldering and not cause any problems. And it's hard to know whether you should treat those people or not if they're perfectly well and have the criteria for myeloma but are otherwise perfectly healthy. So there seems to be a continuum from MGUS to smouldering myeloma through to overt multiple myeloma. Treatment for multiple myeloma consists of chemotherapy. Thankfully, it's usually gentle chemotherapy, which doesn't upset the person too much at all. And generally, people are in the elderly age group. I mean, it can occur at any age, but generally 60s, 70s and above, it gets much more common. The standard treatment for somebody who's over 70 would be melphalan and prednisolone therapy, which has been around for years and is relatively safe. People don't get the expected chemotherapy side effects of hair loss or nausea or anything else. Occasionally, melphalan will cause some diarrhea. That's not very common. And the major side effects come from the high-dose prednisolone, which thankfully is only given for 5 days each cycle. And most people don't get too many problems from that. So I think melphalan prednisolone's still got its place in elderly people with myeloma. It helps to keep the disease under control for a bit longer, and it will help prevent lots of the painful complications of myeloma. Alternatively, in younger patients, we try to be more aggressive these days to try and lengthen their lifespan from myeloma, and more aggressive treatment is used. So often we'll start with, well, we used to start with things called VAD, which was infusional chemotherapy, vincristine, adriamycin and dexamethasone. That was a big nuisance because it had to be given by infusion over 4 days, so they were attached to the hospital or to an infusion pump for that length of time. Now we've got oral therapy which works as well, so things like cyclophosphamide, idarubicin and again steroids are useful to bring the tumour burden down. And then we go on to do stem cell mobilization, collect stem cells from the patient and then use high-dose melphalan therapy to try and obliterate as much myeloma as possible and rescue them with stem cells so they get a transplant from themselves. And anybody up to 70 who's reasonably fit and well would be a good candidate for that. And that's certainly been shown to increase lifespan and reduce morbidity. In the old days, we would think of it as a fatal disease with a lifespan of about 12 months from diagnosis. With treatment, with things like melphalan in the old days, low-dose melphalan, it might get to 18 months or 2 years. Nowadays, we're looking at the average survival of being almost 3 years now, and that's across the board. So if you're 85 and get myeloma, you know, that's going to influence the statistics. But in younger patients, the survival is longer than that, 5 years, maybe up to 10 years these days, if they have autologous stem cell transplantation. And these days, even with the institution of newer therapies, there's quite a lot of work and new drugs coming along to help with relapsed myeloma. So there are things like lenalidomide, Velcade, are all drugs which can be used after transplant, or in some cases before transplant, that will help prolong survival, and they've certainly been shown to do that. So the 5-year survival is now something like 25%, whereas 50 years ago it was almost 0. And the 10-year survival rate's about 12% for multiple myeloma now. And I think there are still developments to sort of come with the management of myeloma. And certainly myeloma is one of those conditions which certainly could be treated with liaison with a haematologist in the local setting. Oral therapy is available, so they don't need to be anywhere near the hospital as long as they've got blood count, electrolytes, calcium monitoring, that's all fine. The treatment of bone disease is a lot easier these days. You can either give intravenous biphosphonates. For myeloma, it's usually either pamidronate or Zometa, and they can be given as, well, particularly Zometa, as a 15-minute infusion once a month or less often in the maintenance phase. Or there's oral Bonphos biphosphonate, which can be given to help with the bone disease. So certainly it's a lot easier to give treatment out with the major centres, and GPs can certainly be involved in that quite easily these days.
Thanks to Dr. Steve Ward for taking the time to speak with us for tonight's program. David, Steve was talking about developments in myeloma. What's happening in the general picture? Where's the focus of research? What's new?
Well, actually, and I've gone on record in haematologists' meetings as saying this, I think now anybody who says they know how to treat myeloma is a fool, because there are so many new treatments that we're really going through a process now of working out how to integrate the old standard treatments with what's become available. So there's something like 10 or 12 therapeutic options now for myeloma, and the trick seems to be playing the right card at the right time for each patient.
What about research? What's new in research, and how far have we come?
Oh, look, it's a fantastic time to be in haematology. In my professional lifetime, 15 years as a haematologist, the prognosis for at least 3 of the main tumour types we treat has markedly improved. With myeloma, I'd say, I'd demur a little bit with Steve's figures that he quoted in his talk. So for example, I started the Charlie's bone marrow transplant program in 1996, and we've now done over 250 autologous transplants, so-called. I know Kathy doesn't like the word. And our 5-year survival is sitting at 50% post-transplant for myeloma.
And the research continues. Kathy, what's new in your area in childhood haematology?
Well, in childhood acute leukemia, the new thing last year was that finally in our best subgroup of patients, the low-risk patients, the outlook is now so good that we can't do a randomised controlled trial. The statistics are too hard, so that means over 95% long-term disease-free survival with few or no long-term side effects. So low-risk leukemia has been officially put to bed.
That's very positive, isn't it?
Yes.
Yeah. Thank you both for being with us tonight. Felicity, the conference, another plug for the conference.
Yeah.
The 26th and 27th of April. It's going to be a great weekend at Burswood. The registration brochure is out. I believe it's available on the website. If you haven't registered, please do. It's going to be a fantastic conference. That's our program for this evening. Don't forget, if there's any part of this program that you'd like to review at a later time, a delayed transmission of the Rural Doctors program will be available via internet web streaming next week. Now, this service is accessible through the Rural Health West website at www.ruralhealthwest.com.au, but do note that the internet transmissions are password protected, so if you haven't already, you'll need to register by contacting Rural Health West. Do be warned too that this service works best for those with high-speed broadband. We'll be back again on the 6th of May with another of our hot tips and general practice programs. It's designed to give you the opportunity to ask anything and everything related to your practice. We'll have an expanded panel of experienced GPs to answer your questions, and the program will also feature discussions with Professor John Murtagh, who spoke with Olga Ward when he was recently in Perth. We look forward to your company then. For now, from Dr. Felicity Jeffries, from our panel, Dr. David Joski and Dr. Catherine Cole, and to everyone else involved in the program, and most of all, thanks to you for taking the time to join us. Good night to you.